Hello and good afternoon or good evening, and welcome to the webinar, Scanning for Partially and Fully Edentulous Workflows, application with the Straumann Series X3. And this lecture will be presented by Ron Roach. And now it's my extreme pleasure to introduce tonight's guest lecturer, Mr. Ron Roach. Ron is a business development manager for software and cloud platforms at Straumann Group with more than 30 years of experience in the medical and dental industry. He specializes in digital dentistry, including CAD and CAM technologies, guided surgery, and integrated clinical laboratory workflows. Ron has held leadership roles supporting the development and adoption of digital solutions for dental professionals. He is an experienced speaker and educator delivering programs focused on improving workflow efficiency, enhancing collaboration, and supporting predictable outcomes through digital implant dentistry. Welcome, Ron. It's all yours.
Thank you, Nicole. Appreciate that introduction. And hi, everybody. Yes, my name is Ron Roach. I'm obviously with the Straumann Group, but I think most of what I'll be talking about tonight is applicable to most scanners. And it's a very interesting topic, scanning for partially and fully edentulous workflows. That is such a broad category. Everything from that first patient who presents edentulous and needs a new denture to a patient who has a denture and just needs a remake, a patient with a partial that needs to add a tooth to the partial. There's a lot of different scenarios in this. And I think the focus I'm going to take is on the scanning for these workflows, because each of these workflows might require a different set of scans, and your laboratory and DX, of course, will always tell you what scans they need. The challenge is, how do we get those scans? And that's what I'll be talking about tonight. So let me jump right into it. We've got a little PowerPoint that should take about the first maybe third to half of my presentation, but then we'll be going live in the software, picking up the scanner and doing some scanning. That's the fun part always. So let's go ahead and jump in. All right, let's come over here. The agenda, we just talked about it. I'm not going to go through that again. As far as the scanner itself, there's a slide here on the scanner. I'm not going to go over each one of these points. If you have the scanner, then you know that we've probably trained you already. We went over all this. And if you don't have the scanner, I'll leave this for your sales rep. It's a neat scanner. It's a new scanner to the Straumann Group. We bought the company that makes it, and it's lightweight. The only feature on here that I will mention is that the holding of this scanner is different. A lot of previous scanners, you might have held it with a fist grip, okay? The newer generation of scanners, SIRIOS and others, are much smaller, and it's very comfortable to shift to a pen grip, okay? And you'll see me doing that tonight. And that's probably the most significant change with the newest generation of scanners on the market, is that they've gotten much smaller, much lighter, and it makes the gripping of the scanner as a pen rather than using the fist much easier. And that helps with your maneuvering in the mouth. As far as the rest of the points on here, it's one of the newest, latest scanners. So we can just assume that all that is newest and latest status. All right. So in the software, there are 5 different workflows on the home screen. Okay, and some you can see are very uniquely, specifically defined, and others are rather general. Okay, and under simple scan at the very top, that on the subtext it says appliances. And what are appliances? Appliances are full dentures, partial dentures, bite splints, night guards, space maintainers, and a whole bunch of other things. Okay, but appliances certainly includes tonight's topics, which is edentulous scanning. So we'll be using the simple scan workflow. There's nothing wrong with using the other workflows to capture edentulous arches. You can capture an edentulous arch in any workflow. And as you get used to the scanner and get used to the various options in the different workflows, you might find that a different one works better for you, and that is fine. The workflows are not restrictive in terms of what you can order from the lab if you scan in a different workflow. The workflows simply guide you through the upper, the lower, and the bite in different ways for different purposes. So I'm going to focus tonight on the simple scan using the appliance workflow. So we click next here, and here's the screen you come to. The reason I like this screen is it is a very simple lab script. All we have to specify when we're setting up a treatment plan for a simple scan is whether we are scanning the upper arch, or are we scanning the lower arch, or are we scanning both arches? And almost always for appliances, you'll be scanning both arches, which is the default choice when you open up this simple scan. So there's really nothing to do on the treatment planning page. You're going to scan both arches, okay? But that's a very general, generic treatment plan or scanning plan, okay? So you will need to add into the notes field some instructions for the lab tech, okay? Do you want their premium denture? Do you want their standard or basic denture, whatever the lab calls those various things? You can put that in the notes. And if you don't want to type it, you can enter audio notes as well. The SIRIOS software will record your note so the lab tech can hear your instructions live. Okay. One note though, when you go into a voice note in SIRIOS, a lot of people think or assume that this is a voice to text converter. It is not. It is an audio recording. So the lab tech will literally be listening to your voice when they hear that note, but you can type or speak your notes into the scanner. Okay. Once you're done setting that up, you move on to the scanning page. And here you see my workflow says lower, upper, and bite. Okay. That's because in my settings in the scanner, I have it set to always start in the lower arch. You don't have to always start on the lower arch. You can start on the upper arch. You can start wherever you want. There are different orders to the scan that you can specify in settings. So don't be thrown off if your scanner does something different than mine here in terms of the order of the scan. That is set in preferences. And by the way, the sample scenario I'm setting up here is patient has an existing upper arch and we need to remake it. So we do a reline and scan that reline denture so the lab can remake the denture. That's the scenario I'm setting up here. So we're going to scan, in my case, the lower first, so the opposing first, then I'll do a 360 scan of the denture. I'll also show you later on how to scan the edentulous arch directly. But in this case here, we're presuming our patient has an existing denture. We're going to reline it and we want the lab to make a duplicate. So we'll scan the opposing. There's my opposing. If you look closely, the patient has fixed hybrid on the lower, just the only model I had. But yeah, so we scan the opposing, okay? And then we move on and it's time to do that 360 scan of the denture. And this is one of probably the more challenging kinds of scans to capture. It is very technique sensitive and it confuses the software in a lot of scanners, okay? So what we're going to do when we do a 360 scan of a denture, okay? So I've got a denture right here. It's important to understand that the most important surface for the laboratory is the intaglio, okay? You've just done a reline. Now, I didn't do a reline on mine. I don't have a patient to reline it on, but let's presume there's impression material all here. Okay, so you've done a basic wash impression. And that's the surface you want to capture. Okay, that's the most important. That's the critical surface. Because that's the critical surface, we're going to capture it first. Okay, so there's the intaglio of my denture. All right. And there's an optical illusion here because we're looking at a negative, we're looking at the intaglio. You might think this arch is facing towards you. This arch is facing away from you. You'll see that in a moment. But after you capture the intaglio, then what you need to do is you need to capture the other side of the denture. And how do we do that? We're going to do that by looking up from the edge, at the edge of the flange. We're going to look up along the facial surface all the way around the denture and slowly build that facial surface around the denture, one or two teeth at a time, okay? Once we've completed that facial surface, okay, so we have the intaglio, we have the facial, okay? Now it's time to get the occlusal and palatal surfaces of the dentition. Since we have the facial surfaces, that's easy. And those of you that are experienced with intraoral scanners, you know that each time we extend the scan, we have to overlap with the existing scan. So if I go back here, okay, I originally had the intaglio, that's easy, okay? Then I looked from the intaglio over the sidewall, over the flange, and up the facial surface. And that's how I captured this. So every aspect, every tooth here was caught by looking up at this angle, and it overlapped with this surface here that I had previously captured. So that kept me accurate capturing the facial. Go all the way around the arch, capturing the facial from the bottom, looking up the side. Now I want to capture the occlusal, so I need to angle my scanner so I'm looking at the facial and the occlusal. And we build in like that. And then once I've got the occlusal captured, then getting the palatal side of the tooth, we overlap looking at the occlusal and the palatal and fill that in, okay? And last thing we fill in is, of course, the palate. The reason we're filling that in last, and I don't mean the intaglio of the palate, the dentition side palate, that's the least important surface, okay? If we start going a little bit off course or create some double surfaces here, that's not critical. It's not a failure in the scan if you do, but you should be able to capture it. It is difficult. Most dentures, this surface is very shiny and has very little contour to it. So it's hard for the scanner to maintain dimensional accuracy capturing the palate. We do have a feature, shine control. And when I was scanning, I turned that on when I got to the palate because I was having some trouble capturing it. And the denture I have here, that's a very shiny surface. So it makes it difficult to capture, and there is no contour at all. It's just smooth. So I'm going to do this live in a few minutes, and you're going to see when I get to that surface, it's a challenge. And that's okay because that's not a critical surface. The important thing is to accurately capture the intaglio and then up the sidewall to the dentition, capture the dentition, and then if we can capture the palate, that's great. That's a bonus, but it's not critical to what the lab needs in terms of their work. Okay. All right, so there's the scan, and then of course the bite is taken like any other bite, okay? When I get to this live, you're gonna see me struggling because this denture and this lower do not go together, but it's all I have to show you with, so that's fine. Well, I'll be holding it together. When you do this, in many scanners, because we started with the intaglio of the denture, sometimes this will, when we do the bite, it'll flip it over, show it upside down. The software knows that this is the upper and this is the lower, and it will properly label those scans for the laboratory. So if your software in your scanner, whether it be SIRIOS or another scanner, if it ends up flipping things, that's okay. It's just because we started on the intaglio, okay? And that doesn't in any way hamper the scan. So just understand that. So that's one scenario. Patient comes in, they have an existing denture, it no longer fits well. You're going to do a wash impression of the denture, and then you're going to scan the antagonist, the 360 of the denture, and do a bite with the denture back in the mouth and deliver those scans to the lab to make a duplicate denture. That's scenario number one. Of course, there's also the scenario where a patient presents and they don't have an old denture. They lost it, they broke it, they never had one, it's their first denture or whatever, and you need to scan an edentulous arch, okay? So that is another type of scan that is very technique sensitive. Both of these are advanced techniques as far as scans are concerned. Okay, advanced scans, and they are very technique sensitive. So these are things that you will want your staff to practice on. This is not something they're going to get right on the first time they try it. I'm going to go over some tips and tricks for you this evening, tell you how to best accomplish these scans. The takeaways from the first half of the presentation here is your lab will specify what scans they need. Okay, given the situation, they'll tell you what they need. And then in the SIRIOS software, you can capture any scan they ask for. Okay, whether it be just 360 of the denture with the antagonist, that's the most common scenario, or whether they want the scan of the actual edentulous arch. If they're going to start from scratch, we can do that as well. All right. Let's go ahead and jump into the scanning. So I'm going to jump out of the PowerPoint here. Okay, and I have my SIRIOS software running. Yes, I do. And I think my screen is still shared. Yes, it is. Okay, so I'm going to jump into a simple scan. Both arches, I do have to put a patient name in. So I do have a patient name named Test Me. Okay, there we go. And we will hit next. And wake my scanner up so it can connect. Okay. My scanner had gone to sleep because I was babbling on so long. So all I had to do was just push any button to wake it up. The green ring is now flashing, and you can see on my screen here, it's now connecting, it's talking, and it's connected. And oh, phew, my battery's at 96%. A couple weeks ago when I did the other one of these programs we were talking about the implant workflows, I think I connected and my battery was half of that. It was a little scary. Okay, so my scanner is connected. I can tell that right up here. Okay, over on the left side, my workflow calling for the lower arch first. So I have my lower arch right here. And the lower arch is simple. Patient is in a fixed hybrid. So I'm just going to turn on my scanner with the top button on the scanner. That turns on the scanner. And from there, we're just going to come around do my occlusal scan first, and we'll wrap, come to the lingual. Let me just get in here. I just told you earlier to use a pen grip, and I wasn't using the pen grip, okay? And now I'll come around and do the facial and rotate in the anterior. And of course, I'm doing what I tell everybody not to do. And let me explain what I just did there. Because I'm presenting tonight, I'm watching the screen and watching what I'm scanning. I never do that when I'm actually scanning because that creates, oftentimes you go off course and you get these double services. Great example of what not to do, okay? So let me pause scanning, delete this, and start from scratch again. And this time I'll keep my eyes on what I'm scanning. You can scan with your eyes on the screen, you can scan with your eyes on what you're scanning. What I find very difficult to do and never found anyone do successfully is scan with their eyes going back and forth. And that's what I was just doing. So let me try this again. This time I will have my eyes on the subject, okay? Okay, so this time, what I did, I ensured that each of my passes overlap with each other. So I did the occlusal pass first. When I come around and do the lingual, I made sure that the white light of my scanner was projecting onto the occlusal and lingual surfaces. When I do the facial surfaces, same thing. I make sure that the white light of my scanner is projecting onto both the occlusal and facial surfaces. And that's how it gives you that dimensional integrity, dimensional accuracy as you build the arch. Okay, so there I have my antagonist, nothing edentulous about that. That's a fixed hybrid sitting on a ridge, of course. And now for my antagonist, for my not that's the antagonist, for my actual arch, let me stop scanning. Yep, hit the second button on my scanner to move forward the workflow. Now you notice that it's calling for the upper, and now I'm scanning the denture. And that is, of course, the star of the show. So for the denture, as I mentioned, the most critical surface is the inside of the denture. So I'm going to do that first. I'm just going to start with, it's a negative. So I'm going to say the ridge first. Of course, I'm scanning into the denture, so it's a negative of the ridge. But let's go ahead and do that. We'll start here. We'll come right around the arch. Keep my eyes on what I'm scanning. Okay. And now in that ridge, I'm going to turn and make sure I get up to the flange all the way around the arch. Okay. Turn again, come this way. Okay, so I've got all that. And now let's come to the, I guess we'll call it the palatal side. Let me come back in. I just skipped a little bit there. Each time I notice a little bit of a little dimensionally inaccurate surface there, you'll notice I go back to a known surface and just come back over to fix that little anomaly. Okay. And then we come back over this. And let's fix that as well. And it will redraw that and fix it very nicely. Okay. So there, I have the intact. Let me turn off my scanner for momentarily to show you that what I have here, let it do its little clean thing. Okay, so this is the inside of the denture. Okay, it sometimes looks like it's coming at you, but it is actually going in to the denture here. Okay, so now I'm going to try and capture the facial aspect. Okay, so I reacquire underneath the denture, turn over the edge, and look at that, there's my teeth. And then I go a little further back onto the flange and do the same thing. And notice that I'm overlapping constantly. I'm not trying to go too far afield from the existing known denture. At each point, I'm just okay. And now I come a little further forward, building that facial aspect of the denture, keeping it connected to the flange. That's where I say this is very technique sensitive. I've seen many people, they'll come up here and then immediately try and go over the top and go all around. But I'm capturing each of these teeth and keeping it connected with this known surface, okay? And that's how we maintain our dimensional accuracy in scanning a denture like this, okay? So I'm just building those facial surfaces from the flange. Oh, lost it. There we go. Okay, come on. There we go. Like that, and like that. So now, as I mentioned in the slides, okay, my cleaning, yep, let it do its cleaning thing. So I now have the intaglio, okay, and again, that's the critical surface, okay. I have the facial aspect, and now I just need to fill in all this. Now I see I have some junk back here, okay, and I don't want to keep that junk in my scans. I want to take this opportunity just to trim that right off because that is not, I don't know if that was my finger or what that was, but that is not accurate. So we'll just get rid of that right there. I just noticed that. All right, so now we can go back and we can continue. We'll work from the facial surface to build the occlusal, and then from the occlusal to build the palatal. So I come back into my denture, starting with the facial surface here. It recognizes it right away. I turn and capture the occlusal. And now we'll just come around the denture from the facial and build to the occlusal. Change my grip. Just giving it a chance to get that accurate incisal edge. Coming back here, now to the canine. And the idea here, I hope what you're seeing is that I'm always going back to a known surface and then just extending that known surface. We don't want to go too far afield and let dimensional inaccuracies come into our scan. So now I'll just fill in that occlusal scan. And now let's go to the palatal surfaces. I have enough of the occlusal that I can extend my palatal surfaces. Get my finger away from there. Okay. And now at this point, I would argue that, let me pause this for a moment. I have all the critical surfaces. Yes, some laboratories want you to fill in the palate, and we will fill it in right now. That is going to be the most difficult of the surfaces to capture, is this right here, okay? But we have all the critical, we have the dentition of the, oops, I got a hole, I got to get that. Mesial of the upper right first bicuspid, okay. So we have the intaglio, we have the flange, we have the dentition, okay? So filling in the palate is going to be last because it's the least important surface to capture and the most difficult at the same time. So let me go ahead and fix that hole first, okay? Now I'm going to turn on my shine control. I've got oops, there's a little finger over there. I've got a on-screen menu. I can do that. I push and hold my scan button down, and there's my menu. Let me come around to shine control. I'm doing it this way rather than going to my mouse or my screen because if we were actually working with a live patient and their denture, we'd be gloved up and contaminated right now. So I don't really want to touch the computer while I'm gloved up, contaminated. so I just use the on-screen menu. All right, let's fill in that palate. So we're going to come across here. Okay, realign on those teeth, come back across. Okay, come around here, realign on these teeth, come back across. Okay, let's come back across again. Okay, come back over here, realign on these teeth. I'm always going back to known surfaces. Okay, because that's how we keep our scanner honest, keep it accurate. Okay, let's come back around here. It's funny, I have my overhead lights are turned off right now. And last time I did this, I had overhead lights turned on and it worked better. All right, it's losing me on that high part of the palate. Just that one part, it says, hey, I don't know where the surface is because I can't see anything. It's all reflective and smooth and there's no contour. I'm going to change the setting here. Didn't mean to turn off my scanner, causes it to clean. Okay, I'm going to change this one setting here and let's see if we can fill that in. Give it one more shot and see how much we can fill in. Come on, you can do it. You can do it. I know you can. Let's come from the other side, smooth out those dimensions. And the little areas that are floating in space there, I'm not worried about those. Those will be taken away during cleanup. That contour should catch it. A thought just occurred to me. The direction I'm holding my denture is reflecting light from outside. Okay, let's go with that. Let's clean it up one more time. All of this junk and this junk goes with the cleaning. That's why I'm not worried about that. There we go. And there's our scan of the denture. Obviously, a few anomalies here on the palate, but as I mentioned, that's the most difficult part to get, but that will not impact the lab's ability to create a new denture from this. The intaglio is the important part. The flange is probably next most important. The dentition is captured accurately. That little anomalies on the palate will not impact the workflow. Now we go ahead and I should be on my scanner, not on my mouse. Go ahead to the next step. Okay. Where'd my lower go? Okay, so here's my lower. Okay, and
Ron,
yes,
we did have a question.
sure.
One of the doctors is asking, could you rub articulation paper on the palate or use sort of a marker?
So yes, tissue markers, articulation paper, yes, because these scanners today, and maybe I've been scanning too long, but the scanners today are scanning in color. Yes, if you can add any texture in the form of a tissue marker or articulating paper, that absolutely will help. I don't happen to have one here, but yes.
I will share. So I don't know how well you
Yep,
can see it.
I can see it. Perfect.
Can you
Yes,
see it? Yeah.
absolutely.
So it is a barrier material. You can get it on Amazon, and then it has a light cure to it. Used it today, and it worked really beautifully.
Oh, no kidding. An actual curable material on the palate.
Yeah, so it's truly three-dimensional.
Yes. Okay.
And you can just flick it right off.
Yeah, a three-dimensional working. Oh, and it doesn't stick, so you flick it off. Nice.
Yes.
Yeah. What's that material called again? Hold that up again. What's that?
It's called gingival barrier.
Nice. Okay. Yeah.
And I ordered it from Amazon.
Got it. Okay. Good tip. Appreciate that. All right, so the bite, and now you'll notice, yes, my denture is upside down here. That's okay. Now that's not, it's still gonna be labeled the upper scan, the lower scan, the lower scan. So that's not an issue. You will see that commonly. So now I'll just capture the bite. There we go. And flip the lower. Okay. And we'll capture a bite on the other side. And again, I'm trying to hold these together. They do not go together well. Okay. So it's holding them upside down, which is fine. They are labeled correctly as soon as the cleaning is done. Okay. So there's my upper and lower scans. Okay. And now we go to review. At this point is where most of you that have scanners know that this is where your actual STL and PLY files are being created. Up until this point, you're just looking at a cloud of data points that were captured. Now we're actually dissolving those data points into all the triangles that make up your STL and PLY files, and they will be done in a moment and ready to send off to the laboratory. So that is the most common denture scenario. Patient comes in with an existing denture. You're going to do a wash impression. Obviously, I got no impression material in here, but if I did, that will only make the capturing of the tag even easier because the impression materials are easy to scan. But yeah, that workflow would hold true for anyone that comes in with existing denture. Now, as soon as that processing is done, I want to show you how to scan an edentulous arch. Okay, it's a little bit different, and again, advanced technique, but something I'm sure you'll be able to master with a little bit of practice. We'll go ahead and do that as soon as this processing finishes here. And if you have any questions while this is processing, feel free to ask. You don't have to leave at the end, or you can if you want. That's totally up to you. Okay. Whenever I see this process, it makes me, my background is engineering. I'm not a dentist, I'm not a technician, I'm an engineer. So when I see this, I know how much math the software is doing right now, creating all those triangles. And that always leaves me just amazed at how quickly it does hundreds of thousands of triangles to make up our STL and PLY files. All right, so that was scenario number one. There's our scans. Yeah, I put them upside down, but that doesn't really matter. Like I said, they're labeled properly and ready to go off to the lab. Okay. All right, let me go back to our home screen and I'm going to go back into another simple scan. Okay. I'm not going to bother with both arches here. I just want to show you how to scan an edentulous arch. Okay. So I'll just do a single upper arch. Okay. And hit next. Oops. Can't hit next till I give it a patient name. Software does force you to identify your patient before you start scanning. Okay. And now I can hit next. There we are. Okay. So my workflow here is just the upper arch. There is no getting your scans ready. Didn't I start a new scan? I thought I created a new case. I did. Okay. Let me see what it's working on here. It's connecting to my scanner. Yes, it is. There we go. Okay. That was an interesting message, getting your scans ready. No previous scans. This is a new case. And my workflow, you'll notice now, just includes the upper arch. There is no lower, there is no bite because I specified a single arch scan. Okay. Obviously, if you're scanning a patient, edentulous or not, you're going to need the antagonist and the bite. I just want to show you the technique for an edentulous scan. So most of it is very much similar to a dentate arch. You're going to start by building the arch with a full occlusal. There's no T, so it's hard to call it occlusal, but a full scan of the ridge. So I'm going to turn my scanner off, start in the posterior, and just come right around and build that ridge. Okay, I'll swing to my facial now and come around. Again, I'm overlapping with my, what I'll call my occlusal pass. Okay. Oops, I'm seeing a little bad data building there. Let me come back to my occlusal, fix that. Okay, turn to my facial, overlap, and continue my facial pass. Okay. All right, now we want to just rock to the palatal side of the arch. Okay, and come around the arch. Whoops, same thing, same issue. It's edentulous, so the software is a little bit more challenged in building it. All right. And come around. Okay, starting again to go off. Let's come back to the occlusal. All right. And now, of course, building the palate, same technique. We're going to start going across from one side of the other, starting in the anterior. So I'm going to go across here from one known surface to the other, come back around, one known surface to the other, and fill in as I go. And I am going to switch over to my other soft tissue level. This will help it recognize the soft tissue. I had a discussion with, I work with scanning a lot, but not every day. And I've worked with scanning for a long time, but it's never been my sole occupation. And I was talking with one of our trainers who lives and breathes scanning. And you saw that I just had some anomalous surfaces appear here, and I chose to fix them. Okay. And what my trainer said to me is, why do you choose to fix it when it gives you those bad surfaces? Why not just dump it and start over? She said, scanners are so fast today that dumping a bad scan and starting over is sometimes faster than fixing bad surfaces, because those surfaces come in and you can see the scanner will fix them. It's very good at doing that. Okay. And so there we have our Edentulous scan with a palette. Let me just try and fix those right there. Okay. And I made it worse. Okay. So again, technique sensitive. There we go. When you have an anomalous surface like that, you can pass the scanner back over it again from a known surface. So I've got some contour in the soft tissue here, and I can pass from there into the area that was giving me the trouble, and it will fill it in and correct those surfaces. But my scanner trainer friend said, why do you bother doing that? Just delete it and start over, because scanners are so fast today that it's less time to start over than it is to fix the surfaces. So that's your choice. Okay. Understand that as scanners get faster and faster, of course, now I'm continuing to scan over and over, and I should stop while I'm ahead. So the technique essentially for an edentulous arch, you're going to build the arch on the occlusal, capture the facial while it's easy. Okay. And then the palate is back and forth and back and forth and back and forth like that. Okay. All right. Let me go ahead and at this point, open things up for questions. Any questions on workflows, different scenarios? That's probably the biggest area where I expect questions tonight, because when we talk about edentulous and partially edentulous scanning, there are so many things, so many categories there. So you've got to have some workflow questions that I didn't talk about tonight. So if you have any of those questions, fire them at me. I'm happy to answer them. If there are other situations, okay, so here I did a replacement denture and the antagonist, and then scanned a upper edentulous arch. But what other scenarios are you facing in your practice? What other scans do you need to do? So fire some of those questions away. I want to open up to questions now. Kelly, I think you said you're going to monitor the questions. I don't even know where to see them if they're typed in.
Yes.
So you tell me what's coming in.
Yes, I am monitoring the questions, and I am not seeing anything.
Come on, people. Yeah, this is a big topic.
We had two earlier, and they were already addressed.
Okay, all right. Anything else for me? How many we still have 38 people in the group. All right, guys, I need some questions.
How well does the SIRIOS X3 scan a vaulted palate, like a really deep palate?
High palates, yeah. Because a great question, because this one is not very deep, right?
Yep.
Okay. So the feedback I've gotten, and I'm going to expand the answer because I started working with scanners a little bit in the 90s with earlier CEREC systems. Then in 2000s, I was working with the early iTero systems and got into Trios systems, and now with Straumann using the SIRIOS. And that high vaulted palate, that is always a challenge. And the challenge in the past has been fitting the head into the patient's mouth close enough to the palate so the depth of field, because depth of field of these scanners is often a challenge. And if the head is too big to get the scanning, the working part of the head close enough to capture that high vaulted palate, especially if it's narrow, you're going to have an issue. I've not myself put this into a highly vaulted palate. I've not specifically heard complaints about that, but I do know that's a very difficult type of scan to capture. This one has a narrower head than average, which should help. Okay. We also did just increase the depth of field. It's now 18 millimeters. Okay. So you should only need to get the scanning window here, 18 millimeters from the roof of the mouth of the palate, and it should be narrow enough to get in that position. I've not done it firsthand, so I can't tell you for sure that it does or doesn't do it well or not well, but I would say the geometry of the situation is better on this scanner than our prior scanners. Or I've got the T6 right here, and I don't know if you can see this. The SIRIOS is a couple millimeters narrower than the T6 head. So those are the factors that would impact those high vaulted palates, is how wide is the head and what is the depth of field. So we just increased that to 18 millimeters and made the head narrower compared to our earlier generation. So those two things should help you with highly vaulted palates.
Thanks. Here's another one. You scan the palate of the smooth denture, but had a hard time creating a perfect image. How long does it take to scan a perfect palate image ready to send to the lab?
Of the denture, I would say this one is ready to send to the lab, because this this surface is the critical one, and I would say that's perfect.
Yes.
Okay. The flange here is about as good as it gets. The dentition is fantastic. Let me turn off the lower. Okay, the palate is not perfect, but the denture is not going to be duplicating this palate, right?
Correct.
Okay? The lab needs to know the dentition and the intaglio and the flange. And so by starting with the intaglio and then building the flange from the intaglio, that is the important thing. I see too many people, they'll come around here, they'll get to a tooth, and once they get to the tooth, they start going around. I'm like, no, you got to build that entire flange before you start scanning the rest of the teeth. And then by the time you get to this, let me think, I've maybe once or twice had a perfect palate, okay, here. And the time it takes to do that, it's not worth it because the lab is not duplicating this. Okay. So yeah, I wouldn't spend too much time making the perfect palate scan. It's not worth it.
Because the premise of this is that it is a reference denture with a wash impression inside of it, right?
Yeah, exactly. Yeah. I think I just saw a question pop on screen about the same high vaulted palate we just talked about. But then the person also mentioned the deep vestibule. So in the scanning function, I didn't talk about this, and perhaps I should have. You saw me change this soft tissue level a couple of times. So there's 3 soft tissue levels in the SIRIOS software. And what this is, so the first level on the left here is the aggressive filtering of soft tissue. Okay. Denture is not soft tissue. Okay. But the software sometimes is fooled to think it's like soft tissue. So this left-hand button here is the aggressive filtering of soft tissue. If you're thinking of your crown and bridge scans, this would be inlays, onlays, crowns, veneers. Notice I didn't say bridges, okay? Inlays, onlays, crowns, veneers. The middle button here allows the scanner to go further afield from what it perceives to be dentition, okay, to capture more soft tissue. In the first setting, it's only going to allow 2 to 5 millimeters of soft tissue from the dentition. Okay. Here, I don't have a number for you, but it's much further afield. So think long span bridges, but to your question, you just asked about deeper vestibules. So if you want to capture a deeper vestibule, you'll need to go to this middle section here. The one on the right actually turns off the soft tissue filter altogether. And I should have mentioned that for this scan, you would definitely want, the software this isn't tricking the software. This isn't soft tissue. It's plastic. But if this were an actual edentulous patient, you would need to turn this filter off altogether.
Just if you were scanning the fully edentulous patient intraorally.
Fully edentulous arch in the mouth, you'll want to turn this off. Just remember that if you turn off this filter, then the software is not filtering any soft tissue. So if you accidentally point it at a lip, cheek, or tongue, guess what? It's going to capture that.
Get it. Yeah.
Whereas on these 2 settings, it automatically recognizes and ignores lips, cheeks, and tongues. You turn the filter off, which you have to do to capture intraorally edentulous ridge, then your brain becomes the filter. Don't have the scanner turned on when you're going into or out of the mouth, because as it passes the lips, it will see them and capture them. Okay. Yeah.
I did have a question that came up earlier and I wanted to ask you about it. So I believe there's a way to switch arches if you've accidentally scanned on the wrong arch. How do
not yet in
how do you
SIRIOS.
swap it?
Yeah, not yet in SIRIOS. There are in other
Not in
scanners.
SIRIOS. Okay.
Yeah, other scanners have that feature, and I have suggested it to our developers, but not yet here.
Got
If it says to capture the lower, you want to be capturing the lower because we don't have a way to switch it. I will say, not to point back at you guys at NDX, but in the lab software, it's not hard to do. So if you do scan an upper and lower arch in the wrong orientation, I wouldn't necessarily delete it and start over because the lab can.
No, I probably wouldn't.
Just
Yeah.
put a note in there, go into the note field and say, hey, I swap the arches. The lab tech can take care of that when they get it.
Perfect.
Yeah.
As dental professionals, we tend to be perfectionists. So
Yep, absolutely. But yeah, that is one feature we do need, and I have requested it. So I would expect that in an upcoming version.
Sure.
Yeah. Any other questions, folks? What do we have? We have 37 people left. Oh, we lost one person. We had 38 a minute ago.
Oh no, we lost somebody.
Ron, I just want to say thank you. What a great presentation it was. I learned a lot more than what I didn't know before, so thank you very much.
And here was a great comment that thank you for sharing what a not perfect scan looks like.
Yeah.
That double imaging and to go ahead and delete it and start again. Sometimes that's a battle for us or a challenge in describing what do I call it? The good, the bad, and the ugly, right? Like here's good, here's bad, and here's terrible, deleted.
Scanning technology has come so far. The first intraoral digital scans were taken in 1986? Okay. Actually, here we are 2026. So we're 40 years later. This technology has come so far, but just like polyvinyl siloxane, you still have occasional imperfections in the scan. And what you need to do when you see an imperfection is assess, is this critical to my indication? Is this a critical failing that's going to prevent my lab partner from doing what they need to do? Or is this just, let's say you're taking a crown and bridge impression with PVS on a number 12 prep, and there's a big polar tear over by number 3, 4, 5. Does it matter?
My favorite phrase, is it impactful to the fabrication of the restoration you're prescribing? And if it isn't, don't sweat the small stuff.
Exactly. And that's why I say this little imperfection right here, that is not going to impact the fabrication of a replacement denture at all. Yeah. So don't sweat it. We have the dentition covered, we have the flange covered, and we have the integral covered. And that's what's needed for a duplicate denture.